Very good afternoon, friends. Welcome you to the second webinar, second part of the webinar series done by our society, Clinical Infectious Disease Society. And I have a few announcements to make, and I would like the audience to key in those questions pertaining to this talk. Because you're going to have another 4 lecture series, and please key in those questions which is relevant to this talk. And I believe that we could just accommodate 1,000 of the interesting people, and others, they could easily go into the YouTube thing. All they had to do is, your friends, if you're joining in late, something like that, please type CIDS Webinars in YouTube, and then you will be able to access it live. CIDS Webinars, CIDS and Webinars. That is what you have to do for the late attendees. Probably you can tell your friends that you have to do that. And welcome. And then it's just reversal of roles. And previous day we had an exciting lecture by Dr. O.C. Abraham, and then Dr. Ram Gopal Krishnan was the moderator. And now it's going to be Dr. Ram Gopal Krishnan, who is a senior consultant in infectious diseases at Apollo Hospitals, Chennai. And he will be the speaker, and Dr. O.C. Abraham will be the moderator. Over to Dr. Ram Gopal Krishnan and Dr. O.C. Abraham.
Thank you very much, Nambi. Good afternoon, everybody. It's a pleasure to welcome all of you to the second of the webinar series hosted by CIDS. It's my pleasure and privilege to introduce today's speaker. Is Dr. Ram Gopal Krishnan, a good friend and colleague. He can be described as a pioneer of ID in India. He finished his training in the US, came back to his home country, motherland, leading ID consultant in Apollo Hospitals in Chennai. He's also an adjunct professor of infectious disease at the Tamil Nadu Dr. MGR Medical University. To me personally, he's a very good friend, a man of eclectic interests, unparalleled as a clinician, as a teacher. RGK will be talking on patient evaluation, treatment approaches, review of drugs, and chemoprophylaxis. And we will keep all the questions till the end of the talk. So over to you, RGK.
Thank you very much, OC, for that generous introduction. I hope my voice is audible to all. Is that audible to all? Yeah. Okay. So now the shoes on the other foot. I get to the tough part while OC gets to ask the questions. So this is what I'll be covering today. We'll start off with patient evaluation and just some basics to start off with. So when will you suspect COVID? We all know this. We've been with this disease for the last couple of months at least. Anybody with an acute respiratory illness and a history of travel or residence in a location where there is community transmission of COVID, which essentially means countries other than India or areas in India where there is community transmission, which is believed to be at a low level right now, or anybody with respiratory illness and in contact with a confirmed or probable COVID case. Also, anybody who is severely ill enough to end up in the hospital and without any other alternative diagnosis. It shouldn't be bacterial pneumonia, should be other viral pneumonia. You would call this a suspect case. A probable case is one in whom you suspect this clinically, but you can't confirm it on testing, or you couldn't do the testing for whatever reason, it's not available, or for whatever reason. A confirmed case, the one that goes into the statistical record, is one with a confirmed, laboratory confirmed COVID infection, which at this point is an RT-PCR test, irrespective of whether the patient is symptomatic or asymptomatic. So having defined our COVID patients, what do we do when these patients present? So there are 4 things you need to do. You need to screen and triage. You need to decide which case could be COVID. You need to take appropriate infection control prevention, which is going to be an entire 2 or 3 lectures. You need to do lab testing, which will be a full separate lecture, and clinical management based upon severity of illness, which we will deal with partially during this session. So when these patients present to a hospital, you need to be aware that these patients may transmit the infection to you and to other patients in the hospital. So screening should take place at the first point of contact. This should typically be at the entrance or just outside, whichever patient care clinic you're involved in. Anybody who has any of the suspect definitions, anybody with illness, give them a mask, direct to a separate area where the healthcare provider appropriately protected. In other words, essentially droplet and contact precautions make this distance between the patient and the healthcare provider and between patient and patient. This is the first to avoid transmission to the healthcare provider. So who to test? Now this is a busy slide. These are guidelines. I'll come to the Indian guidelines in a minute. But what they say is you triage patients on severity of symptoms. So first of all, the most severe symptoms go to those who are healthcare facility workers with symptoms, then those who are vulnerable, then those who are mildly ill, and finally those without symptoms. So just expanding the first part of that guideline, you have to ensure that you test anybody who's hospitalized and who could have COVID and healthcare workers. The second reason is because of two reasons. One, healthcare workers are critical in fighting off this epidemic. Two, healthcare facility workers can transmit to others. So these are the priority pay for testing. Now the ICMR has come out with a revised version of COVID strategy in India, which was updated as recently as yesterday. The guidelines said test everybody who has been traveling abroad or anybody who's a contact of a confirmed case. They extended that to all symptomatic healthcare workers and to those with any severe acute respiratory illness who needs hospitalization and as well as contacts. Even if the contacts is asymptomatic, after their incubation period of 5 days is over, you test them once. As of yesterday, they have updated their website to include people who are in hotspots or clusters. Now, what is a hotspot or cluster? You will have to check with your public health officer, depending on which part of the country you're practicing in. And in large migratory gatherings, evacuee centers, essentially congregate centers, all symptomatic ILI. This is important. It means just a minor cough, fever, sore throat, to all the way to obviously people who are more symptomatic who needs hospital admission. And they say within 7 days, you do a direct test, which is an RT-PCR. After 7 days, you start with an antibody test. And if it's negative, you confirm by RT-PCR. The confirmatory test for COVID remains an RT-PCR. Testing will be taken up in detail by Dr. Rajiv Soman in one of the subsequent lectures. So having diagnosed COVID, the approach to this patient depends upon who is likely to die from this disease. So the people who are likely to die, you follow a more aggressive approach, you put them in the hospital, and you certainly should introduce whatever treatments we have. Those who are not likely to die, who tend to do well on their own, you don't need to admit, and you can follow a less aggressive approach to them. So as far as India goes, these are the health ministry data, which suggests that in India, if you're above 60, you have a mortality rate of about 9%. Younger than 60, you generally tend to do well. The comorbidities are listed there as well. Diabetes, hypertension, or a combination of these, but the most important comorbidities, asthma, lung disease in a significant minority. So if your patient is in any of these categories or above age 60, you have to be correspondingly aggressive with admission and treatment. So if somebody has mild to moderate disease and certainly absolutely no pneumonia or hypoxia, if they have no underlying chronic symptoms or chronic conditions, you advise them home care. Provide symptomatic, any other symptomatic treatment, counsel them about the risk of spread, self-quarantine them in order to mitigate community transmission. Whom do you admit? Older patients, you can say the cutoff may be about 60 or so, although that is arbitrary. Those with comorbidities, diabetes, hypertension, chronic lung disease, or any other comorbidity, even though they may present with mild symptoms, have a very, very low threshold for admitting them. And certainly all patients with severe disease automatically would end up getting admitted. This is just one of many treatment protocols which have been devised for COVID. This is a busy slide. So let me start with the top half of the slide. You obviously suspect it when you have fever in association with respiratory symptoms, which Dr. Osi went over yesterday, or even these unusual symptoms like loss of taste or smell, myopericarditis, or in this day and age, if you are having fever for more than 72 hours without a diagnosis, please think COVID. On the left, if your saturation is good, your vital signs are stable, you have reliable follow-up, then you go into A category. On the right, if you're severely ill, saturation is bad, you have end organ damage, blood pressure is dropping, you fall into category C. Obviously, category C goes straight into the hospital, perhaps straight to a CCU. A is managed as an outpatient. And in between, you take a call depending upon whether they have comorbidities, whether they are age above 60 or so, whether you need to admit them, whether you need to do further testing, at least a chest X-ray and a CBC in these patients, at the very minimum, make sure those are normal before saying they can be managed at home. Moving on to drugs, what do we have available to treat the patients who are admitted to the hospital? I am not going to dwell into intensive care aspects too much. Intensivists are better qualified to do that. But let's see what works, what doesn't work for COVID. Now, one of the big problems, which I'm sure Dr. O.C. encountered yesterday, was that there's not any peer-reviewed literature. If I think that something works for COVID, then I just put it in the abstract form, send it to a poor quality journal, and it's all over the news the next day. So look at the number of preprints which have taken off, as opposed to printed peer-reviewed literature which you can rely on, which has been studied by others and accepted as quality work. So this is the big problem we have with COVID, especially when it comes to treatment recommendations. Now, this is a general schema which has been sort of thought as happening in COVID. Earlier on in the first few days, it's largely non-specific symptoms, at which point you might see the typical laboratory abnormalities, which Dr. O.C. spoke about yesterday, lymphopenia, etc. And at this point, certainly antiviral medications would help. Then they perhaps go into a pulmonary phase with worsening shortness of breath and dropping oxygen levels. At this time, obviously, chest imaging is abnormal. Certainly, antivirals are important here as well. But at some point, perhaps about 5% of these patients have an exaggerated post-inflammatory response. I mean, in other words, even if you don't have comorbidities, even if you are a young person, rarely you can go into this post-inflammatory phase, which causes a great deal of cytokine storm and puts you in ARDS, septic shock, I wouldn't say septic shock, shock, cardiac failure, and all these inflammatory markers like IL-6, LDH, etc. go up, and you get into trouble. And it's thought that at this stage, this is when you need something to dampen the host inflammatory response. So numerous medications have come out trying to work at this stage. So at all stages, you need antivirals, and perhaps in the most seriously ill patients, you need anti-inflammatory medications. And it goes without saying that using an anti-inflammatory medication without good antiviral therapy may be foolhardy. We know that from other viruses and bacterial sepsis. So in a single slide, these are some of the more important treatments for COVID. On the left, you have antivirals, chloroquine, and its less toxic derivative hydroxychloroquine, convalescent plasma, lopinavir, ritonavir, and remdesivir. There are numerous other, you can say, wannabes who want to be on that antiviral list for COVID. And on the right, possibly the two most important or probably the two most promising candidates in terms of their anti-inflammatory properties. Again, many drugs waiting for an indication, which we'll discuss in a little more detail today. I'm not going to go into the critical care aspects of COVID, such as intensive care, oxygen, proning, etc. That surely should be done by an intensive care physician. So what are the antiviral drugs that we have? Now, one basic problem is we are dealing with a virus. It's not a bacterium. And you may say that the bacteria are all getting resistant, but at least you have something to which they have become resistant. Here you have nothing. So don't hold your breath too much. If you look at the evidence, it's a virus. So ultimately, you have to wait for the body's immune system to do your job. This is a review article, a treatment which I have referenced later, which basically tells you what drugs work against COVID. You can see here that some of the drugs that work for SARS-CoV-1 in 2003 and MERS-CoV, the Middle East virus, also work for SARS-CoV-2. Hydroxychloroquine, on the other hand, a widely used drug now, has been best studied for SARS-CoV-2. So we hope that these drugs will translate from in vitro activity to clinical studies into guidelines. Now, as you can see in the next few slides, that path is not very straightforward or smooth. We will start off with chloroquine, very ancient drug, very cheap. The theoretical mechanism of action is it interferes with the cellular receptor ACE2, which Dr. Osi described yesterday, and therefore it might work against both SARS-CoV-1 as well as SARS-CoV-2. It also impairs the acidification of endosomes, which interferes with virus trafficking within cells. Perhaps it might work best if given early in an infection. And experimental data shows that you can easily achieve clinical blood levels. It wasn't active in the animal models of SARS, though. There were reports of favorable outcomes from China, but again, no publications in the peer-reviewed literature. And so I won't deal with chloroquine any further because essentially we have moved on to hydroxychloroquine. Now, I'm sure there's not a single person in the audience who hasn't seen this, this very seductive slide. You know, just start hydroxychloroquine and down, disease over, patient well, and this is the drug of choice. Now, it turns out that this particular paper from the French group from Marseille, France, did have some problems with methodology. I think it's an underestimation to say it's not the perfect study. There were only 42 patients, first of all. They had 16% of patients who were asymptomatic. Now, why would you give therapy to an asymptomatic patient? How would you assess response? 60% had upper respiratory symptoms. And as per guidelines, we don't even test those patients, let alone treat them. Only 22% had lower respiratory symptoms as defined by, say, bronchitis or pneumonia. And interestingly, there were a lot of patients lost to follow-up in the hydroxychloroquine group. 3 patients were actually transferred to the ICU and 1 died. Now, as a clinician, I'm interested in keeping my patient out of the ICU, definitely interested in they're not dying. I don't care what the viral load is doing if they are doing well. And even the viral load, several patients continue to have a positive PCR. Now, you may say that PCR could represent dead virus, live virus. We don't know because it wasn't a culture, it's a PCR test, but still the PCR test was positive. And so some people say there's no real evidence to say that HCQ and azithromycin worked. And interestingly, the sponsoring society for this paper, the International Society of Antimicrobial Chemotherapy, accepted that perhaps this wasn't a very great quality paper. Now, this is another study. It's not a peer-reviewed article. It has been published. However, importantly, this was a control study. The previous study was a non-controlled, just a case series. Here, they gave hydroxychloroquine in a slightly lower dose. They did exclude severe illness, critical illness. And what they concluded was the HCQ group resolved 1 day earlier before the control group. And the CT scans also got better, a little quicker. As you can see, at least this had a control arm. So it's a basic study, but at least it had a control arm to tell you what you would do without any treatment. And you can see here that fever resolved roughly about a day earlier, progression to severe illness, perhaps a little less. We don't know, numbers were too small. Okay, and here the CT scans also got better a little bit quicker. So in a small controlled study, you had about a 1 day improvement in illness. Many of these patients were just moderate or mildly ill because severe illness was an exclusion category. Now, the other point of view is there is actually a paper suggesting that theoretically chloroquine, hydroxychloroquine could be harmful. Now, it turns out that these medications reduce IL-2, which is important in the so-called Th2 response to the virus, and perhaps you could be impacting it negatively. We don't know. This is just a viewpoint. However, practically no other viral infection has responded to hydroxychloroquine. So this is something which people are worried about. In so many years of treating viruses, we've not found hydroxychloroquine effective against any virus. Really, is this something worth trying? Now, just earlier today, apparently a new abstract has been released. I don't even know which journal. This is just the abstract saying this is what they have done. They plan to publish this, certainly not even peer-reviewed, but they did study. The same group of French investigators looked at 1,061 COVID patients. At least they looked at a large number of patients, and they found that about 91% got better. A relatively poor outcome only in 4% patients. But I thought the most important take-home point of this study was no cardiac toxicity was observed. So I think that's reasonable. If you put 1,000-odd patients on hydroxychloroquine and nobody has sudden death, that is reassuring. Their conclusion was that the combination of hydroxychloroquine and azithro, when started immediately after diagnosis, safe and efficient treatment a little optimistic, I might think, because this is not at all a controlled study. We don't know what these patients would have done on their own, but still, let's see what happens when this actually gets published. Now, one big problem is some of us are having to relearn how to read ECGs. You know, we have forgotten what is a QTC interval. We're having to relearn all that stuff. And you can see that COVID patients, they already tend to have cardiac disease. Remember, they can have myocarditis, etc., cardiac injury, NT-proBNP goes up, troponin goes up. On top of that, when you push in drugs like chloroquine, hydroxychloroquine, lopinavir, ritonavir, azithromycin, is just an antimicrobial soup. And you can see here the number of cardiac events in a large registry, US registry, showing that drugs like hydroxychloroquine, when thrown in, can easily cause the death of a patient. This is something you'll need to monitor very closely. And 3 major US cardiology associations have come out with this guideline, which is very useful and practical. If your QTC is more than 500, no hydroxychloroquine, LPV, RTV, etc. Please monitor the rhythm and QT interval daily. Withhold if it's more than 500. And another practical problem is going in ECG leads on this patient. Taking careful ECGs is a big headache. Remember, these are all critically ill patients, so you can't monitor them very well. And please watch their electrolytes, potassium and magnesium very, very closely. Avoid other QTC prolonging drugs, as if the ones we are using are not enough. The second drug, which has been actually better studied than hydroxychloroquine, is lopinavir, ritonavir. We know that from early experience with both SARS and MERS, these drugs were promising. Sorry, lopinavir was promising. You can see a rapid reduction in viral load in this viral load study. MERS, actually, this drug worked quite well as post-exposure prophylaxis with no healthcare contact getting infected while on this drug for prophylaxis. There was some very early Singapore experience, about 5 patients with this drug. 3 patients got better, but 2 patients got worse. So really not very promising. But luckily for this particular drug, we have reasonably good data. This is a randomized controlled open label trial in actually pretty sick patient. Your oxygen saturation had to be less than 94, or the PaO2, FiO2 should be less than 300. Interestingly, the majority of these patients got enrolled more than 12 days after symptom onset, which is fairly late in the course of the disease. Conclusion was that there was no difference between lopinavir, ritonavir, and controls. And therefore, this was a negative trial. However, the investigators said that numerically, if you started earlier, there could have been an importance. And so the major limitation of this study was it was given late in illness. You don't know, perhaps if a study comes along, starting this drug early in illness, perhaps it might work. And similarly, the editorial on this suggested that it just wasn't a particularly good inhibitory drug for SARS-CoV-2. And this is a challenging population, severely ill patients. Perhaps that's why it didn't work. Now, remdesivir has been widely used in the US on a compassionate release protocol from the company. It is not available in India. It's a broad spectrum nucleotide prodrug. It's got a history of working, of being tried in vitro versus other RNA viruses. It is a parenteral preparation. The side effects are there: abnormal LFTs, nausea, vomiting, decreased appetite, headaches, etc. As of now, this is in many trials. These are 3 trials, but this is the biggest trial, the randomized placebo-controlled trial, which actually has fully recruited. So we are waiting for information on this drug. Let us see what happens when this data comes out. At this point, not available in India. One very promising treatment which has very recently come out in the last couple of weeks is convalescent plasma. Now, these are fairly critically ill patients. They're fairly seriously ill. Severe pneumonia with a low PaO2, FiO2, mechanically ventilated. They took plasma from convalescent patients, make sure it had adequate titers, both by ELISA as well as neutralization titer. But even here, these patients stayed for enormous periods of time, 50 days. Okay. So as you can see, convalescent plasma is an emerging promising modality. One advantage is this may well work out to be a lot cheaper than many of the expensive drugs which are in trials right now. So moving on to anti-inflammatory therapy. Now, corticosteroids are the first drugs we obviously reach out for when we have any autoimmune problem complicating an infectious disease. Now, the previous experience with corticosteroids for infectious diseases for viruses, lung viruses, hasn't been that good. You can see that with influenza, there's an increased risk for mortality, and even the prior two coronaviruses, there were problems and a lot of side effects. So perhaps people were not too enthusiastic about corticosteroids when they started off. However, this retrospective study, this is a large case series from China, and in patients who had ARDS, you can see there's a clear difference in between those who got methylprednisolone and those that did not. You can also see that this was a significantly different number. So perhaps corticosteroids may work, but then again, this is retrospective data. We still don't have a prospective trial on corticosteroids. Hopefully that will be done. The other drug to be looked at in patients with severe disease is this IL-6 inhibitor called Tocilizumab. This has been well studied for other diseases, rheumatologic diseases, macrophage activation syndrome, cytokine therapy, storm after CAR T-cell therapy, etc. It is an expensive drug. It certainly should be reserved for severely ill patients if you do use it. And 2 doses, 8 mg per kg IV, divided into 2 doses is what is recommended if you do use this drug. What is the experience with Tocilizumab? Again, this is a preprint, not a peer-reviewed literature. 21 patients who got this drug seem to get better, both clinically as well as CT-wise. These are just some images from that paper, and also showing that things like CRP, temperature, FiO2 got better. However, again, there were no controls. This is just a case series. And again, this is not peer-reviewed literature. Now, for any new disease, especially one that has high mortality in severely ill patients, there are a lot of new drugs coming out. And this is just a list of new drugs which are being looked at. The other protease inhibitors, naturally, once lopinavir ritonavir was used, but perhaps are less potent against coronavirus protease compared to lopinavir ritonavir. You can see many of these immune modulatory therapies are being used. Many new drugs, including other IL-6 inhibitors and this RNA polymerase inhibitor called favipiravir, are in trials. We have no idea whether these will ultimately work. What will give us that answer, however, is WHO's Solidarity trial, which is essentially a large practical trial, standard of care versus randomization into one of 4 arms: remdesivir, hydroxychloroquine, ritonavir, lopinavir, or that with interferon beta. Hopefully, this trial will give us the answer. So what do guidelines say? So this is what most physicians consult when there's a lot of literature, because people go through guidelines and make recommendations for or against. The Surviving Sepsis guidelines say that steroids, yes, they probably would use them. There's a weak recommendation for if there is ARDS. No ARDS, don't give steroids. They also say there's a weak recommendation against lopinavir ritonavir or convalescent plasma, but perhaps these guidelines came out before the convalescent plasma trials, and they couldn't comment on tocilizumab or hydroxychloroquine. What about corticosteroids? WHO and CDC say the same thing. Conventional teaching: don't use steroids for viral pneumonia unless you put them in a trial. The most recent guideline to come out was an ATS, American Thoracic Society-led international task force. They say that if you are hospitalized with COVID-19 and pneumonia, you could use HCQ or chloroquine, but then discuss with the patient, make them aware of the risks and the lack of efficacy, and make sure the drug is not in short supply. They recommend, there's absolutely no recommendation if you're an outpatient. In other words, for mildly ill patients, no data that it works. And all the other drugs, tocilizumab, etc., steroids, etc., they just left those, let those go. They really didn't have enough data to make a position statement. So what are the Government of India guidelines? This is what Government of India recommends. Hydroxychloroquine, this is the dose in combination with azithromycin, 500 mg once a day for 5 days. And again, they say it's really an off-label indication. And this is currently the standard recommended in India. What do I do in my practice? Something like this. If it's a class A patient, mild patient, nothing. Just watch paracetamol, etc. Similarly, for a patient who's got comorbidities, but again is doing perfectly well, except the close-up has to be very, very close. You're seeing these patients on an outpatient basis, probably daily follow-up. The patients who are admitted, the first drug you can start with the hydroxychloroquine with or without azithromycin. The evidence for this alone is stronger than the combination for these two, because at least one, you have a small controlled trial. And the more seriously ill patients, you probably first could be using antibiotics in these patients. Very difficult to rule out a bacterial pneumonia, although it's much less common than in, for instance, H1N1 influenza. And then you could consider any of these therapies. Convalescent plasma, tocilizumab, or steroids. The 2 and 3 are available in India. 1 is not yet available, but perhaps it will be available. Certainly, we can't give concrete recommendations on one drug or the other because there is just no literature. What about chemoprophylaxis? Now, the idea behind chemoprophylaxis is that hydroxychloroquine, once you load it, sticks around in your blood for a long period of time, up to 1 week. So all you need to do is to take this once a week, and potentially it might be useful early on in the viral process. So that is the rationale behind hydroxychloroquine. And this is the recommendation for hydroxychloroquine by the Indian government. They suggest that if you're a healthcare worker looking after COVID patients, not if you're just a healthcare worker, not going anywhere near these patients or staying at home. You have to be looking after them actively. Or if you're a contact of a laboratory confirmed cases, you could be put on hydroxychloroquine. This is the dose recommended, a loading dose followed by 400 mg once a week, and obviously avoid in patients with other issues, retinopathy, children under 15, etc. An unresolved question is, do you need to monitor in patients on prophylaxis? Because if you have an elderly contact, for instance, are you going to do a baseline ECG? What are the risk benefits in that setting? We don't know, because there's no data on which we base this recommendation. There is no study actually showing that hydroxychloroquine prophylaxis works. And you might have a false sense of security. I'm taking my hydroxychloroquine. I won't fall sick. I won't be strict with my PPE. These are highly dangerous attitudes. So this is my my final slide. Please suspect COVID, not just in travelers and contacts, but also in any severe respiratory illness, healthcare workers, and in community clusters. Please take care right from the beginning to avoid transmission to yourself and to other patients. Admit only moderately ill or severely ill patients. Very little data for most drugs. Hydroxychloroquine may help, but again, it's a cardiotoxic drug. Consider chemoprophylaxis, but once again, no scientific data behind chemoprophylaxis. Thanks to Dr. Vishnu Rao and Dr. Kiran Kumar, Dr. Krishna Prabha for help with these slides. And our major conference is later on in Kolkata this year. I'm sure you will hear a lot more about COVID in that conference. Thank you very much.
Thank you. Thank you very much, Dr. Ram Gopal Krishnan. That indeed was a very exhaustive review of literature. Thank you again for sharing your personal experience, treatment protocols in Apollo Hospital, Chennai. Now it's time for questions and answers. So I will read out the questions which have been coming to me. First question is about ivermectin. What is the dose of ivermectin in adult and pediatric age group?
It works very well for strongyloidiasis, works very well for scabies. If you're in Africa, it would work for lower. No data in humans versus COVID.
Okay, thank you for that. Second question is about role of JAK inhibitors. Can you please elaborate on the role of JAK inhibitors in COVID-19 therapy? Because it's a major signaling pathway for cytokine production. In mouse, there are promising results.
That's true. There are promising results in vitro, no clinical data. There are trials which are enrolling for these agents in US, in resource unlimited or well-resourced countries like US or Europe. No clinical data. Certainly, I would discourage use of expensive agents like this without clinical data, because potentially these are all immune suppressive patients. We don't have good antivirals. See, we have a really good antiviral. Suppress the virus, and then you can try anti-inflammatory therapies. We don't have a good antiviral for COVID. So it's a problem. So unless you have clinical data, I would wait and avoid.
Thank you. How can we clinically differentiate COVID from influenza?
Clinically, it's a little difficult. I think you should take that question, Dr. Osi. You took clinical features yesterday. Do you want to take that?
Actually, clinically, there is no way to differentiate. It's just another viral respiratory tract infection. Travel history today if there is ongoing community transmission, travel history also does not have any. Even the so-called symptom of ageousia and anosmia, if you carefully ask, a proportion of influenza patients also report that. Next question is about sensitivity and specificity of RT-PCR. If the test is negative, but you still have a strong clinical suspicion, should we repeat the test? If so, when?
Yeah, this question will be dealt with in detail by Dr. Rajiv Soman in one of the subsequent lectures. Just to say that no test is 100% sensitive. Highest in BAL, 93%. Then it falls to 80% in sputum. By the time you get to the nose, it's down to 40 to 50%. So no test rules out.
You have answered this question, sir. Do the travel history is relevant today? You answered this. Even your concluding slide said that that is not relevant today. Next question. I don't know whether it is relevant for our, it's about hotspots and quarantine. Nowadays, people are escaping from quarantine and hospitals. Do these hotspot concepts are reliable or not? That is the question.
Concept? Yeah, I think the government is trying very hard to work on these hotspots. So as an Indian, please cooperate, please follow what the government says. It is public health, it is all of us that are involved. Please take the government's guidelines very seriously and follow.
Next question is the role of anti-CD147 monoclonal antibody Meplozumab trial in China showed a better outcome in patients. CD147 has interaction with both protein, S protein and N protein of the SARS-CoV-2. Although sample size is low, 38 patients, there is 67% reduction in viral load and around 56% better outcome in patients. Please opine, sir.
I think you know more about it than I do. Thank you for the information.
Next question is about if a patient of SARI comes with no history of contact or travel, is he supposed to be admitted in a COVID and swab to be sent? This question comes because the COVID hospital load will significantly increase as any breathless patient is being sent to COVID hospital.
Yeah, so this infection control precautions will be taken up later, but in brief, when you admit somebody with severe acute respiratory illness, you send them to two separate places. One, a SARI ward, where the diagnosis is not confirmed, where you've sent a test, awaiting the test. And second, somebody with confirmed COVID. If a SARI patient is confirmed with COVID, they go into the COVID ward. This is to separate these patients and avoid non-COVID patients getting infected if you send them directly to the COVID ward.
Okay. Next question is, sir, is there patients presenting with anosmia in India?
You want to take that, Osi?
We have seen very few patients here. Although we have not specifically asked for the history of anosmia, nobody has reported anosmia as such. Next question is about convalescent plasma therapy. The convalescent plasma therapy in COVID-19 patients, few of the articles suggest to use the plasma when the PCR is positive and seronegative stage. Your thoughts on this?
No, I think you mean the reverse. The PCR is a sign of active disease. We don't know whether the virus is live or dead, but it should be negative and you should have clinically recovered. You should have IgG antibodies. They do neutralizing antibodies and ELISA. These protocols are being worked up, but you should have absence of active tests for the virus and presence of immunity to the virus. Only then you can take plasma.
Next question is about HCQ prophylaxis. Should all doctors take HCQs prophylactically?
Absolutely not. I'm not taking prophylaxis, although I don't see a lot of COVID patients. I know that many of my colleagues who are seeing COVID patients are not on prophylaxis. The problem is there is no data. Now, I understand that there are so many heroic healthcare workers looking after these patients, but if it doesn't work, then why take it? It's not a non-toxic drug. It has some side effects. So I would not recommend it to any older patient with cardiac disease, other medications. If you're young and healthy and you were seeing a lot of COVID patients, then yes, the ICMR guideline certainly allows you to take it. So what we need is data, and hopefully that will be there in at least a couple of months to see whether chemoprophylaxis works.
If I may add to that, if you're planning to take hydroxychloroquine, please read the ICMR guidelines and only high-risk contacts should be taking it. Next question is on azithromycin. Are there other macrolides, sir, other than azithromycin, other macrolides has any role?
None has been studied to the extent azithromycin has, but at least clarithromycin has many similar properties to azithromycin. Might work, but we need a study saying that.
Next question is about the role of azithromycin in treatment regimen. I think you mentioned that in your several, you reviewed the literature, you showed your treatment protocol. The next two questions are on hydroxychloroquine as prophylaxis. You answered that. Whether chloroquine phosphate is as effective as hydroxychloroquine?
Yes, it probably is as effective. The data on chloroquine comes from China, which is again not published, preprint, all those limitations. But hydroxychloroquine is less toxic, that most people accept. And we have a long experience with long-term therapy with hydroxychloroquine for SLE, RA, etc. So it's well versed for long-term therapy. But we don't know. We ultimately, actually, the Solidarity trial includes chloroquine as well. We need data, but at this point, most people would prefer hydroxychloroquine over chloroquine.
Next question is, if cardiac events are low, then why not use HCQS plus azithromycin as prophylactic drugs?
Double QTC prolongation, most important, no data. Okay, so no data, absolutely no data that will work, and you'll surely be at risk for azithromycin-resistant bacterial infections.
Next question is again on convalescent plasma. Although you answered the question, sir, the convalescent plasma were taken from sicker patients or relatively stable patients?
Very few patients. As I said, initial trial 5 patients, other trial 10 patients. I don't think they looked at the severity of patients. You had to have confirmed COVID, recovered, and then have an antibody titer which was above a preset limit. I had that in my slide. So I don't think the severity of the illness matters. It is what is the titer of antibodies in your blood that matters.
Again, you answered this question, but again the question comes, should HCQS be used to treat all positive patients?
I would not use it for outpatients. Simple, because there is no data. At least for inpatients, we have some weak data, and that too in the middle group, the moderately severe group. But for outpatients, there is no data. It's a big problem dishing out hydroxychloroquine, loading doses in somebody who might get better on their own. It's a complete waste one, and it might actually cause toxicities. So I, at this point, certainly would not use it in class A or very mildly ill patients.
Next question is not about treatment. Since 1/4 of the cases from the current scenario are symptom-free, what precautions we should do to tackle this in order to prevent the communal spread?
Social distancing. That is the only way you can prevent spread from an asymptomatic contact, because nothing you can do. So don't shake hands, don't step out. Please observe lockdown carefully.
Is there any ongoing study in India?
India is part of the Solidarity trial. Is going to be part of the Solidarity trial. In addition to that, many intra-institutional or group of institutional trials are starting up. So certainly there's an opportunity. If you have an opportunity to participate in these trials, please do so. But that's the only way whether we know that drugs are working.
Are there any ongoing trials on ACE2 blocking antibodies?
Actually, I don't know. I didn't see that in any of the newer therapies, list of newer therapies that were there, and I don't know the answer to that question.
As far as I know, also there are no ongoing trials on this one. Next question is, sir, the role of ivermectin as seen its role in vitro by Australian study.
Yeah, again, it's an in vitro study, and people love ivermectin because it's cheap and you can easily write a prescription for it. But I don't think it's that simple. We really need to study it in humans. Even retrospective data we don't have. I would certainly not use it at this point.
Which superadded bacterial infection is common after COVID-19 infection?
Actually, there's only anecdotal data on that, but most of the studies, severely ill patients, we seem to see that they don't have the frequency of pneumococcal or staphylococcal infections, which classically kills an influenza patient. That was well documented as far as 1918 in the first influenza pandemic. It's the pneumococcus that kills you after you get influenza, but that doesn't seem to be the case for COVID-19. It is largely viral, Having said that, in a severely ill patients, antibiotics to cover pneumococcus staph aureus are reasonable, or if you've been on the ventilator for a prolonged period of time, you fit criteria for WAP coverage for hospital-acquired infections is reasonable.
Which parameter should guide for Tocilizumab therapy?
We don't know. We don't know. People tend to draw IL-6 levels, but IL-6 levels are all over the place. Sometimes they are even higher after you finish the Tocilizumab, anecdotally. So I don't know. Draw IL-6, draw serum ferritin, LDH, CPK, all these markers of severity. We have cytokine storm, class C patients. Probably your patient may be a candidate for Tocilizumab. Whether it works or not, we don't know. But possibly worth trying. Try to enroll your patient in a trial.
Sir, is there any role for broad spectrum antibiotic, especially for sick patients in ICU? You had answered that question, but you want to emphasize that point again?
Yeah, I would not give broad spectrum antibiotics. If somebody is in class C, severely ill, then at the most coverage for pneumococcus, H flu, MSSA, that is methicillin sensitive staph aureus, amoxiclav, something like that. Broad spectrum antibiotics will only predispose to your ICU flora getting in.
Can NSAIDs be used in COVID positive patients, confirmed positive, or in patient who could be a COVID positive? Any contraindications?
Yeah, generally NSAIDs are a bad word, let alone COVID. They are a bad word when you're dealing with any patient. They tend to reduce renal blood flow, gastric ulcers, etc. There is some data that they can actually make COVID worse, anecdotal data. So NSAIDs are unnecessary. Just stick with paracetamol.
Again, a question on prophylaxis. What prophylaxis for pregnant doctors treating COVID patients?
Actually, pregnancy is not thought to be a risk factor for severe COVID, unlike the situation with influenza. So ideally, if somebody is pregnant, if they could be allotted non-COVID work, that is ideal. But if they have to take care of COVID work, just use your PPE and go ahead and do the work. Typically, a pregnant person is young, 20 to 40 years or so, should do just fine, even if they get COVID.
Does Tocilizumab help COVID patients?
Nope. We wish it did, but it does not.
BCG vaccine role.
BCG vaccine, again, there is no clinical data. Certainly, nobody has initiated a trial, not even retrospective data. There is just a map showing that perhaps in countries which had more BCG vaccine, or rather countries that are BCG vaccinated, there was less COVID. It's just a map. I don't know. We certainly need data, because this is a cheap intervention. So if somebody could do a proper trial and show that BCG reduces COVID, that would be great, but no data at this point.
Next is a long question, but I'll read it out for you, Ajike. Any particular reason why HCQS is being preferred over LPVR? The secondary endpoints, including 28-day mortality in COVER trial, was lower in LPVR arm despite commencing treatment late. Statistical significance was not reached, probably because the sample size was not powered for 28-day mortality. HCQS on the other side is recommended on the basis of viral load trial by Gottred, which was uncontrolled.
Yeah, I agree with you. If you have analyzed the literature well and you feel that lopinavir ritonavir maybe work, fine, please use it, because nobody can say this for sure. The general reading by most people after that New England Journal trial was, if you started after day 12, it certainly doesn't work. If you started earlier, maybe it might work. We don't know. We are waiting for more trial data. But if you have analyzed the literature in depth, then please use what you think might work. Consensus guidelines tend to favor hydroxychloroquine. For instance, the Indian government guidelines, they had lopinavir ritonavir earlier. They've taken it off now.
If I may add to that, the concern was power of the study. So that's why WHO has included it as an arm in the solidarity trial. Next question is, what is the dose, duration, and indication for steroids in COVID-19? This is from Dr. Sunita Reddy.
Well, steroids, if you use them, have to be in class C or severely ill patients. Typically, what has been used is methylprednisolone, 60 mg per day for 5 days or so. That is what I saw in that large JAMA paper from China, that retrospective data. So perhaps you could do the same. But this actually should be a trial which is relatively easily done. Steroids are easily given. Randomized patients who are severely ill. It's selecting the correct patient. how do you know the patient won't get better on their own? So there has to be a uniform marker of severity into which all patients are enrolled. But 60 mg methylpred for 5 days.
Next is there a possibility of resistance to HCQ if we take it as prophylaxis? Chance of resistance during treatment?
It is not an antiviral per se. So I don't think resistance is an issue. The question is, does it work or not? It just may not be potent enough to work. It's not like you develop a resistance, mutation, etc. That kind of issue has not been described. And the toxicity. So resistance is not an issue.
Would you recommend ECG and G6PD before HCQ is given?
I would definitely recommend an ECG, a baseline ECG for sure, because anecdotally, you do ECGs on people and it's prolonged. So for sure, if you want to take hydroxychloroquine, I would recommend a baseline ECG. G6PD deficiency is less of a concern to me.
You have answered on ivermectin, antiretrovirals. Is there any outcome data on COVID-19 infection in patients who are on HCQ for long time for SLE and other conditions?
I have not seen that kind of data. We know that immune compromise tends to be a risk factor for progression to severe disease. We know that from other viruses. Here as well, immune compromised patients tend to do worse. But I don't know, I have not seen any data on SLE patients who have gotten worse. Any idea, OC? Do you know? I haven't seen anything.
I have not seen any data. I have not seen any data. You answered on convalescent plasma. You answered. Why is HCQ restricted only for healthcare workers? I suppose he means in the context of prophylaxis.
Yes, that's right. So the indications are you are exposed the most as a healthcare worker, other than contacts as a healthcare worker. Also, to instill confidence in healthcare workers that to keep the health system going, that was one of the motivations behind that recommendation. Again, it's not a evidence-based recommendation, but it's there and an option for you.
We are almost near 4 o'clock. We'll have a couple of questions before we wind up. Is there any role for anticoagulants like heparin in management of critical COVID patients?
Yeah, I have seen data saying that if your D-dimer levels are very high, then that's an adverse marker for a poor outcome. So in those patients, you could use heparin. But having said that, you have to look at the whole picture, the entire coagulation cascade, how thrombocytopenic is the patient, PT, PTT, etc. I think it's sensible to perhaps restrict that to people whose D-dimer levels are high.
We will take this as the last question. What is your experience with Tocilizumab?
My colleagues have used Tocilizumab. Experience is experience. A couple of patients seem to improve, but their IL-6 levels were even worse after the Tocilizumab. Some patients did not improve at all. So it's just anecdotal, handful of patients. So it's risky to rely on anecdotes because it all depends on the severity of the patient. What we need is a trial. So I'm not saying don't use it in severely ill patients, but I'm saying to say that it works, you need a trial. So I can't give an evidence-based answer to your question.
So there are many more questions, still many more questions to be answered, but in the interest of time, we will wind up here. Dr. Ram Gopalakrishnan deserves our appreciation. You heard a master speaking, making a very good effort of reviewing the literature almost up to the minute. He even reviewed Didier Raoult's big paper on hydroxychloroquine. He shared his personal experience, and by the number of questions, it has been raised, we know that it has been a very good presentation. Thank you very much, Dr. RGK. Thank you.
Thank you, Oz.
And thanks to Dr. Nambi for organizing this.
Yeah, you're welcome, OC. And as usual, Ram Gopal pitched in, and then a very beautiful lecture. And I believe there are a lot of questions on ivermectin and HCQ. I would see those questions. I just thought we would reinforce this. HCQ, as per the ICMR guidelines, is for contacts, high-risk contacts of patients proven to have COVID. That is for the general public. For the general public, it's only for the contacts. The one with the healthcare workers, the ICMR is quite clear. This is for healthcare workers who are taking up COVID, proven COVID, or who are expected to take care of COVID suspects. So it's very clear. And success, it's not like that if someone is doing only an outpatient practice, someone in the master checkup, it's not a popping pill kind of thing. It is only for people who are expected to take care of COVID patients. And again, HCQ was the flavor in the initial couple of weeks. The last week it has been ivermectin. And I just will highlight that ivermectin on in vitro has activity in some species of mycobacterium, positive organisms and gram-negative organisms. These are all in vitro data, and there are no real clinical data. And so is the coronavirus too also. Ivermectin has in vitro data, because there are a lot of questions on a daily basis from doctors saying that should be taking ivermectin, because you guys said, okay, HCQ, no. So shall we take ivermectin? I don't think yes, the answer to both ivermectin as well as HCQ as a routine prophylaxis. And again, I think that would bring the end to this session. And again, the lectures will be posted in the CIDS website, that is CIDSindia.org. Yesterday's lecture is already in there. People who have joined late or missed it, please visit the CIDS website to have access to the lectures. And again, the CIDS website has a section on COVID where we have tried to put in authentic material, plus there are a few items from our side too. And there is a YouTube link. So people who have missed the live action, all they have to do is go to YouTube and type in the search button, CIDS webinars. So I'll do that, and then so that you will have access for it as long as you wish. And thanks again for joining for this wonderful session. And looking forward to a much hot topic with respect to the COVID-19, and that is the infection control. And we'll be having Dr. Subramanian doing it tomorrow. And thanks, bye-bye, good day, and we all will meet again tomorrow. Thank you.
Okay. Thank you, Nambi. Thank you, RGK.
Thank you, Osi. Thank you, Nambi.
Welcome.
Thank you, Mr. Seshadri. Bye.
That is a great talk, RGK. Very good. Excellent.
Thank you, Osi. Thank you, Osi. Thank you.